Hello, everybody. Dr. Gavin Gardner here with another short video where today we're discussing something that's near and dear to everyone's heart. That's because we're discussing things that cause ST segment elevation. Now, we know things aren't always what they seem, and ST elevation on an EKG isn't always a myocardial infarction. In fact, there are lots of other causes of ST elevation. And here's a handy dandy little mnemonic to help you remember what those causes are. Let's start first with E for electrolytes because, well, it's the first on the list. When we're talking about electrolytes that cause ST elevation, we're talking about calcium and potassium. When we think of hypercalcemia, we typically think of things like shortening of the QT interval, PR prolongation, maybe increased amplitude of the QRS, but it can be a rare cause of ST elevation. There are a few medical conditions where we see hypercalcemia: vitamin D toxicity, milk alkali syndrome, hyperparathyroidism, which makes sense. But where we're probably going to pick this up the most is in patients who present to the emergency department with a history of malignancy. So here's an EKG from someone who presented with hypercalcemia and ST elevation. You can kind of see the dome-shaped ST elevation, especially in V1, V2, and V3. This EKG might even be a better example of ST elevation in hypercalcemia. Now let's talk about everyone's favorite electrolyte, the death ion, potassium. The EKG changes associated with changes in potassium is well described. With hypokalemia, usually get prominent U waves, and then as the potassium worsens, we notice a progressive change in the EKG from peak T waves to widening of the QRS to the sinusoidal wave, followed by a systole. By and large, the biggest cause of hyperkalemia where we need to intervene is renal disease. There are some other causes to be aware of: crush injury, chemotherapy, maybe rhabdomyolysis. And DKA causes hyperkalemia, but it's more that we need to treat the acidosis associated with the DKA because that's just a potassium shift. And so we don't directly treat the potassium usually with DKA. So this is how hyperkalemia presents on an EKG: peak T waves, then widening of the QRS. And this is when we start to see our ST segment elevation. Then we widen out even more until we get a sinusoidal wave. And then eventually we end up with a systole, which is bad. The little blips are just the heart saying, "Give me calcium, please." Now let's talk about the next thing on the list: left bundle branch block. Before we dive into ST segment elevation associated with left bundle branch block, let's first define what left bundle branch block is, and here's some criteria for that. First, our QRS segment should be greater than or equal to 120 milliseconds. We should also have a dominant S wave in lead V1. We should have a broad monophasic R wave in the lateral leads, leads 1, AVL, V5, and V6, as indicated by those arrows. There shouldn't be any Q waves in our lateral leads. And we should have a prolonged R wave peak time of greater than 60 milliseconds in leads V5 and V6, which just is the time from the onset of the R wave to the peak of the R wave. So here's an example of an EKG with left bundle branch block. So if we say those red arrows represent our J point, which is just that first change in direction where the QRS complex joins the ST segment, and we compare that to our T to P segment, which was what we're measuring against, that definitely looks like elevation. So the question is now, does that represent myocardial infarction? This used to really perplex us, and a long time ago, we even treated new onset left bundle branch block like a STEMI equivalent, but we've come a long way since then. Wouldn't it be amazing if we had some tool or method that allowed us to look at EKGs with a left bundle branch block and determine which ones were really STEMI equivalents and needed to go to the cath lab? Well, the mystical geniuses of medical lore have devised such a tool. Well, I'm not quite certain how they did it, but they took one part Scar from The Lion King and one part Captain Barbossa from Pirates of the Caribbean and wound up creating the Scarbossa criteria. And so here it is, the brainchild of Elena Scarbossa. So she developed a point system based on three different findings. If you had concordant ST elevation greater than or equal to 1 millimeter, you got 5 points. If you had ST depression greater than or equal to 1 millimeter in V1, V2, or V3, you got 3 points. If you had discordant ST elevation greater than or equal to 5 millimeters, you got 2 points. The problem is that you needed 3 points for this to be meaningful. So this discordant ST elevation of greater than 5 millimeters, even though we see it all the time, turned out not to be all that significant. Another problem was Elena Scarbossa's original intent was to identify EKG changes that correlated with CKMB positive MIs. What we wanted were EKG changes that correlated with STEMI equivalence. So along came the Smith modified Scarbossa criteria, and from its origin was supposed to identify changes on an EKG with a left bundle branch block that were STEMI equivalents. They took away all the point system and just came up with these three things. Basically, the first two are unchanged, and the last says that excessive discordant ST elevation greater than or equal to 25% of the depth of the preceding S wave in any one lead rather than 5 millimeters of discordance. So now we have a set of criteria that we can use when analyzing an EKG with a left bundle branch block to identify STEMI equivalency. It turns out that they also work pretty good in patients with pacemakers. At least they work pretty good at ruling in a ST elevation MI, not quite as good on those patients at ruling it out. Now let's talk about early repolarization. And the first thing that we have to discuss when we're talking about early repolling is early repolling a bad thing? There you go. There you go. Well, decidedly for pole vaulters, it's a really bad thing. However, for most of us, it's a benign finding on an EKG. If you dig around long enough, you might find some articles that mention malignant early repolarization. And this would refer to patients who are predisposed for idiopathic ventricular fibrillation. Some would say that it may even be linked to Brugada syndrome, which we'll talk about later. Some of these findings that you'll see on an EKG that has early repol is a long corrected QT interval or a high J wave amplitude or low TR ratio. The most important, most predictive finding would be a pause dependent augmentation of the J wave. So if you happen to see a pause and then afterwards the J wave looks bigger, that is predictive of those patients who may be predisposed for idiopathic ventricular fibrillation. But if I talk about this much longer, I'm really going to get off track and outside the focus of this lecture. So if it's something you're interested in, there are articles out there about that, so you can go look that up. So let's talk briefly about the classic findings that we see in benign early repolarization. First, you get that J point notching, that little notch that you see right at the J point with patients who have benign early repol on their EKG. The ST elevation should be concave. The ST segment elevation should be usually in V2 through V5 and is typically less than 3 millimeters. And the T wave is usually large and symmetrical. Since we are talking about ST elevation, we want to make sure that we can differentiate between the ST elevation of benign early repolarization and the ST elevation of a myocardial infarction. And here are some of those differentiators. There should be no reciprocal changes, no convex ST segments, and no acute evolution. The first thing that you have to know is what EKG leads are associated with certain anatomical regions of the heart. So lead 1, AVL, V5, and V6 are considered lateral leads. Leads 2, 3, and AVF are inferior. V1 and V2 are septal, and V3 and V4 are considered anterior leads. Now we can use the pale mnemonic to determine where our reciprocal changes could be, because we know that a posterior MI, as indicated on this EKG, should give us anterior reciprocal changes. Likewise, an anterior MI will give us inferior changes, and an inferior MI will give us lateral reciprocal changes. When it comes to the shape of the ST segment, convex ST segments are more concerning, like the one on the left, whereas concave ST segments are much more reassuring. And when we talk about evolution, I'm not talking about man starting off as a tadpole in a primordial pool becoming a bipedal organism. I'm actually talking about how EKGs tend to change over time. If you have a patient that you're really concerned about, get more than one EKG. If those EKGs change over time, that should be a concerning feature. Now let's talk about ventricular pacemakers and ventricular hypertrophy. With regard to ventricular pacemakers, we really just need to go back to the discussion we had earlier about Scarbosa criteria, because that's how we're going to determine whether or not the ST elevation from a pacemaker is related to ischemia versus just because they have a pacemaker. You do have to remember, though, that one common reason that people get pacemakers is because they've had previous ischemic damage to the heart. With regard to left ventricular hypertrophy, there are multiple different criteria that you can use: the Sokolow-Lyon index, the Cornell voltage criteria. With the Sokolow-Lyon index, if we measure the S wave in V1 and add it to the R wave in V5 or V6, and we get more than 35 millimeters, then that is diagnostic for left ventricular hypertrophy. With the Cornell voltage criteria in men, if we take the S wave in V3 and add it to the R wave in AVL, and it's more than 24 millimeters, that's positive. In women, if we take the S wave in V3 and add it to the R wave in AVL, and it's more than 20 millimeters, that's positive. The easiest one to remember, though, is probably measuring the R wave in AVL. If it's more than 11 millimeters, that's positive. Just realize that if you only use one criteria, you will occasionally miss left ventricular hypertrophy. So in this example, we have a patient with left ventricular hypertrophy as measured by the Sokolow-Lyon criteria, but just barely. And we see a little bit of ST elevation in V2 and V3. However, the morphology of the ST segment is reassuring in that it is the convex upward sloping ST elevation. And that's in contrast to the STEMI ST morphology, which typically tends to be flat or concave. Now, sometimes this can be hard to pick up and hard to discern. So it's important to let the clinical scenario guide you. If they have all the other features of a STEMI, I would certainly be concerned and be more likely to go down the STEMI pathway. Something else you can do when trying to discern whether or not this actually represents a STEMI or not is look for reciprocal changes. If we're talking about an anterior MI based on the EKG findings, look for inferior reciprocal changes. Now let's talk about left ventricular aneurysm and arrhythmias like Brugada. Okay, so let's all agree that aneurysms are bad. If I had the choice between having an aneurysm and not having an aneurysm, I would choose not having an aneurysm. Left ventricular aneurysm is no different. If given the choice, you don't want one. The way this occurs is someone has a myocardial infarction and they develop a scar on their left ventricle, and therefore that area thins out and is now prone to aneurysm. Since we're looking at the left ventricle, predictably, we're looking at all the precordial leads. Particularly, we're looking at V3 through V4, but they can be in any of the precordial leads, given that V3 through V4 observes the anterior wall of the left ventricle, and V5 through V6 observes the lateral wall of the left ventricle. In this example, we see ST elevation in leads V1 through V3. One characteristic of patients with left ventricular aneurysm is that they have persistent elevation of their ST segment. So, if you were to randomly perform an EKG on an asymptomatic patient with left ventricular aneurysm, chances are they will have persistent ST elevation, even though that doesn't represent an ongoing ischemic event. Another key feature of EKGs in patients with LV aneurysm is the presence of Q waves. After all, these patients have had a previous MI, so that shouldn't be surprising. The T waves are also important to consider in these patients because measuring the T wave can give you an indication as to whether or not this is a new ischemic event or a stable LV aneurysm. The T waves should be less than one third the depth of the Q wave, and there definitely shouldn't be any hyperacute T waves. Also worth noting is that there aren't any R waves to speak of. In left ventricular aneurysm on the EKG, there shouldn't be any R waves. That's one way that we can differentiate between a new ischemic event and a stable left ventricular aneurysm is the absence of R waves, or at least having small R waves. So I'm going to summarize this a little bit. And one of the reasons that we do this is to try and differentiate between a new ischemic event and someone who has a pre-existing LV aneurysm. You could certainly make the case that every time you see ST elevation like that on an EKG, you're just going to call cardiology. And I don't think that's an unreasonable plan, to be honest. But for those who are trying to differentiate between LV aneurysm and a new ischemic event, realize that these are patients with a previous MI, so they already have a lot of risk factors. They do have persistent ST elevation, so if you go back and look at all their EKGs from the time they had their first MI, they're all going to have ST elevation. With LV aneurysm, you'll always find Q waves. And remember that the T wave should be small, less than one third the distance of the Q wave, and their R waves should also be small or non existent. And next up,
Brugada syndrome.
Brugada syndrome is an inheritable sodium channelopathy that is found often in the Asian population. These are patients that show up to the emergency department after a syncopal event, and you find the telltale signs on the EKG. They are at risk for ventricular tachycardia and ventricular fibrillation. If you ask them, some will have a history of a family member who died unexpectedly of an unknown cause. Brugada is treated with an implantable cardiac defibrillator or quinidine. Brugada comes in three different flavors, type 1, type 2, and type 3, but the only ones that seem to get the cardiologist excited is type 1. Type 1 is characterized by the incomplete right bundle branch block pattern that you see in V1, V2, and V3, as well as the coved shaped ST segment elevation that you can see on the picture. Type 2 and 3 are very similar with the saddleback shaped ST elevation, 3 just being a little bit less prominent. Now let's talk about ST elevation that occurs after trauma or treatment, things that we do to patients. As we talk about trauma in this section, remember that we're referring to blunt force trauma of the chest, not penetrating trauma. Since the heart is a muscle, after all, you can injure it from an impact just like you would injure any other muscle. With the heart, we can at least partially evaluate for this injury based on changes to the EKG or elevations in biomarkers like troponin. If an injury to the heart occurs during blunt force trauma, it's most commonly going to be the right ventricle that is injured. Understand also that this trauma can cause direct injury to the cardiac myocardium, but it can also create ischemic injuries from intracoronary artery hematomas, as well as breaking loose pre existing plaques, creating a scenario like acute coronary syndrome. When it comes to ST elevation during treatment, these only require a brief mention. These causes of ST elevation actually occur during certain interventions and actually help guide us during these interventions. One of these procedures is the pericardiocentesis, a procedure done when there is a pericardial effusion, creating cardiac tamponade. During this procedure, a lot of times you'll see someone attach an EKG lead to the spinal needle that we use for the procedure. This will help us determine the depth of our needle. Is the needle in the pericardial fluid or has it actually touched the myocardium? With the EKG lead attached, if the needle is in the pericardial effusion, we see the normal QRS pattern on the left. If the needle is impacting the heart, we see the injury pattern on the right. Another scenario in which ST elevation helps guide us during our intervention is the placement of a transvenous pacemaker. As we're inserting our pacemaker wire, we can look for changes to V1 on our EKG to determine where the tip of our pacemaker wire is. And when we see this injury pattern, we know that we're in the general vicinity of where we should be. Now let's talk about causes of ST elevation related to ischemia and inflammatory conditions like pericarditis and myocarditis. Analyzing an EKG for ischemic changes is the bread and butter of EKG analysis. And the most common reason for us to order an EKG is to rule out cardiac injury due to ischemia. And these are the current STEMI criteria. If you're male and less than 40 years of age, your EKG is positive for STEMI if you have more than 2.5 millimeters of elevation in V2 or V3 and greater than 1 millimeter of elevation in all other leads. If you are male older than 40, your EKG is positive if you have more than 2 millimeters of elevation in V2 or V3 and more than 1 millimeter of elevation in any of the other leads. If you are female, your EKG is positive if you have just more than 1.5 millimeters of elevation in V2 or V3 and still greater than 1 millimeter of elevation in all other leads. Remember that the EKG changes generally follow an anatomical pattern, although the lines between these anatomical regions can sometimes be blurred. You don't always have EKG changes that fit neatly into a specific pattern. You might have EKG changes that look to represent an anterior lateral pattern or a anterior septal pattern. Also remember to look for reciprocal changes, knowing that a posterior MI is only going to give you anterior reciprocal changes. The only way you see ST elevation is if you do a posterior EKG. And remember that anterior MIs give you inferior reciprocal changes, and inferior MIs give you lateral reciprocal changes. Also, don't forget to be a clever clinician. If your history and physical and your gestalt or your gut feeling says that there's something wrong, continue to dig, repeat EKGs, obtain some additional testing. And as this article from the Journal of American Heart Association points out, the interpretation of an EKG is largely dependent on the interpreter. They also point out that the sensitivity for picking up STEMI based on an EKG is only 65% and the specificity only 79%. That being said, EKGs are cheap and they don't impart any direct harm to the patient, so don't let any concerns about their inaccuracies dissuade you from ordering them. Now let's move on and talk about pericarditis. Pericarditis is an inflammation of the pericardium, which is the sac-like structure that surrounds the heart. These patients usually present with chest pain, and classically it's chest pain that worsens when they lie down and improves when they sit up. There are four stages to pericarditis. In the first stage, you see widespread ST elevation as well as some PR depression. You'll also find some ST depression in AVR and sometimes V1. One of the biggest giveaways at first glance, though, is that there is ST elevation everywhere. The elevation on these EKGs don't necessarily fit any typical anatomical pattern. In stage 2 of pericarditis, the EKG changes normalize. This usually happens sometime between weeks 1 and week 3. In stage 3, you see flattened T waves that become inverted. And in stage 4, the EKG returns to normal. Next, we have
Myocarditis.
Where pericarditis is an inflammation of the membranous sac around the heart, myocarditis is an actual inflammation of the heart muscle. Like pericarditis, myocarditis is usually preceded by some type of viral infection. Similar to pericarditis, these patients usually present with chest pain, and they can have EKG changes that mimic the changes that you would find on an ST elevation myocardial infarction. However, unlike pericarditis, myocarditis patients sometimes will have elevations in their biomarkers like troponin, which would be atypical for patients with pericarditis. That can make these patients exceedingly difficult to differentiate between true MI and myocarditis. Next up, let's talk about Osborn waves, which we see in hypothermia. Contrary to what you might believe, Osborn waves weren't discovered by Ozzy Osbourne. They were actually discovered by Dr. John Osborne and are also called J waves because of their characteristic shape. The Osborn or J wave is a positive deflection seen at the J point in precordial leads and is commonly associated with hypothermia. On an EKG, they remind me a lot of early repolarization. The difference is that your patient will be very cold. Osborn waves are seen in the precordial leads, that's leads V1 through V6, and they occur in patients with temperatures less than 32 degrees Celsius or 90 degrees Fahrenheit. Their size do correlate with the temperature, so if they are extremely hypothermic, the waves are bigger, and they do improve when the patient is rewarmed. And now for the last letter in elevation, N, for non-occlusive vasospasm. So, can a broken heart cause a broken heart? Well, that's what's thought to happen in Takotsubo cardiomyopathy. Takotsubo is the Japanese word for octopus pot or octopus trap. And in a case of Takotsubo cardiomyopathy, the heart takes the shape of an octopus pot. This condition is often preceded by some type of emotional stress, like losing a loved one, hence why it is also called the broken heart syndrome. But it can also be seen in times of extreme physical stress, like sepsis. 90% of cases of this disorder are actually found in women. And although the exact mechanism of this pathology is not entirely known, it is thought that non occlusive vasospasm does play a role. Their EKGs are indistinguishable from an ST elevation MI, and they sometimes will even have elevated biomarkers like troponin. So we don't know that they even suffered from Takotsubo cardiomyopathy until they end up in the cath lab and have a negative heart cath. So if Takotsubo cardiomyopathy is a non-occlusive vasospastic problem, then what is Prinzmetal angina? Well, as best I can understand, Prinzmetal angina is everything non-occlusive vasospastic that isn't Takotsubo cardiomyopathy. You do a little cocaine, you get a little chest pain, that's Prinzmetals. Like Takotsubo, you can also occasionally get ST elevation, and you can also occasionally get elevations in your biomarkers like troponin. All right, so we've worked our way through the elevation mnemonic. That should just about cover everything that causes ST elevation. I hope that you found this video useful and at least modestly entertaining.